Okay, so I will start, if you don't mind, with the left atrial appendage closure, because this is related to the topic you just heard before. So I will now switch to my slides. First of all, thank you very much for the invitation, of course. I'm really happy to be there, in some way at least. So left atrial appendage closure for preventing stroke and chronic atrial fibrillation. Some information about the background. I mean, most of you know that atrial fibrillation is one of the most important causes of stroke, especially in elderly patients. And here you can see for data from the Framingham trial, and you can see that especially those patients older than, for example, 80 years, 1/3 of their strokes are actually caused by atrial fibrillation. So although elderly patients have many other reasons for a stroke, atrial fibrillation is the most important, or one of the most important causes of stroke in these patients. So obviously the answer is let's give anticoagulation, and a number of randomized trials have shown that anticoagulation is effective in reducing stroke in atrial fibrillation. You can see the percentage of stroke reduction ranged between 50 and 86% in these different trials. Especially those patients who are very old benefit the most from anticoagulation. When you compare, these are the patients older than 85 years, they had the largest benefit of anticoagulation in preventing stroke and atrial fibrillation. So anticoagulation is effective, but unfortunately it does not work in clinical practice, not with Coumadin and also not with the newer drugs, and I will explain you why. And this is the reason why anticoagulation does not work in clinical practice, because there are so many contraindications, and this list is from the instructions for use for warfarin, and I think each of us, all of our patients have at least one of these contraindications. For example, this would be my contraindication here, lack of patient cooperation, and there are many other reasons why patients cannot take anticoagulation. So, and you're all aware of the narrow therapeutic range. INR has to be between 2 and 3. If you have a higher INR, then you cause intracranial bleeding. If you have a lower INR, then you are increasing ischemic stroke risk. And for all these reasons, there's a huge underuse of anticoagulation, especially in those patients who would benefit most, that is the age group above 75 or 80 years. You can see that only a small percentage of these patients, about 20% of those patients older than 80 years, actually are able to take anticoagulation. And it's even worse if you look on the long-term run. So this is in clinical practice, how many patients can continue to take anticoagulation over a follow-up time of 6 years. That means all these patients initially could take Coumadin or warfarin, and then over time, due to contraindications or other reasons, they stopped it. And you can see that after 6 years, only about 20 to 30% of these patients are still on anticoagulation. And that is true for all age groups. You can see even those very young patients here between 40 and 64, they also stop anticoagulation due to contraindications and side effects. So anticoagulation does not work on the long term. You may say, okay, but new anticoagulants are much better tolerated than Coumadin. That's not really true. These are data from the dabigatran trial, and you can see the permanent discontinuation rate. This is for warfarin, and this is for dabigatran. You can see that actually the stopping rate for dabigatran was higher than for warfarin, and that is due to gastrointestinal side effects. And you may say, okay, gastrointestinal side effects are not important, but at the end of the day, patients stopped taking dabigatran for these reasons. This is in other trials, rivaroxaban, dabixaban. You can see that the stopping rate is in the same range as with warfarin, so there's no difference regarding ability to take the drug between the new drugs and Coumadin. So we will have the same result, I'm sure. We will have the same result for the newer drugs on the long-term run. Are newer anticoagulants more effective than Coumadin? Yes, they are, but the differences are really not huge. This is warfarin, this is dabigatran in the low dose, this is dabigatran in the high dose, and you can see they are a little bit better in preventing systemic embolism or stroke, but the difference are really, the absolute differences are really not huge. New anticoagulants are better than warfarin, so it's correct. There's a trend for dabigatran in low dose and higher dose. There's always a trend for better results compared to Coumadin. But look at the results of the Watchman left atrial appendage closure. It's in the same range. as with newer drugs. So there's not a big difference to left atrial appendage closure. How about bleeding? This is major bleeding with dabigatran. You can see small differences. It's almost the same for warfarin as for dabigatran and for dabigatran, but it's much more important is this is only 2.5 years. So what if the patient continues to take anticoagulation? And they have to, because atrial appendage, atrial fibrillation will not stop. And what happens then over time is that these curves are linear and they're going up and up. So after 5 years you are here, after 7.5 years you are here with your major bleeding rate. What's about other new anticoagulants regarding bleeding? It's the same. These curves are always linear. That means the longer you follow the patients, the more of them will suffer from a severe major bleeding. And new anticoagulants have new problems. There's no reliable monitoring, no antidote. Renal insufficiency requires dose adjustment, and many elderly patients already have or may develop renal insufficiency. Short half-life time is a disadvantage in patients who are not 100% compliant, and dabigatran may cause acute MIs and much higher costs. All anticoagulants in general, coumadin and the new drugs per definition have to be given lifelong, have a bleeding risk. Bleeding risk increases with age. At some point during life, anticoagulants will have to be stopped in all your patients. What does that mean in clinical practice? You should avoid anticoagulants in elderly patients because of higher bleeding risk, and you should avoid anticoagulants in younger patients because they would have to take it for a longer time period. Where do the thrombi arise? You know that they arise from the left atrial appendage. 90% of clot forming the left atrial appendage in patients with lone atrial fibrillation. And closure of the left atrial appendage is therefore a logical concept. This was the first device we used 10 years ago to close the left atrial appendage. This was the first patient in August 30, 2001, who had the first successful left atrial appendage closure. He had his 83rd birthday just a few months ago, still without coumadin and without any stroke or any other embolic event. The Watchman device is the device we are currently using very often. It's the device where we have the best data to support the concept. You can see some images of the procedure. We measure the diameter of the left atrial appendage on TEE as well as on angiography. Then we select the device of a proper size. You can see the device, how it is implanted. And this is the final result. We check the residual flow around the device. We measure the residual compression of the device. And finally, the device is released after a TAC test. Okay, you may ask, well, where is the evidence for this treatment? Well, we have the PROTECT-AF trial, multi-center prospective randomized, FDA-controlled, Watchman versus coumadin, non-inferiority trial, and we are now at 1,500 patient years of follow-up. These are the major in- and exclusion criteria. Obviously, we could include only patients with no contraindications to coumadin because this was a randomized trial against coumadin. So all these patients are candidates for coumadin. These are the endpoints. We had a composite primary efficacy endpoint, all strokes, cardiovascular and unexplained death, systemic embolization, and we had a composite primary safety endpoint, which means device embolization requiring retrieval, pericardial infusion, requiring pericardial synthesis, cranial bleeds and gastrointestinal bleeds, or any bleeds that require more than 2 blood transfusions. Oops, that's not showing properly here. So basically these two curves here are almost overlapping. This is a primary efficacy endpoint, and you can see that Watchman was non-inferior to coumadin, 29% lower relative risk in the Watchman group, which means the Watchman is non-inferior to coumadin. Also, some other significant findings of this trial: all stroke could be reduced by 22% by closing the left atrial appendage. Hemorrhagic stroke was reduced by 75%, and mortality was reduced by 30%. So LAA closure is effective, and the question is it also safe? Well, left atrial appendage closure is an interventional procedure, and interventional procedures in general initially always have a higher risk than doing nothing. And that means the advantages of any interventional procedures can only be expected during follow-up. And that's why we have this initial gap between these two curves. So this is safety, which means freedom from device embolization, pericardial effusion, and severe bleeding. And this is the control group. This is control, this is the watchful group. So these are the initial complications which occurred after closure of the left atrial appendage. But what you can see is that over time, these curves are merging. And also most of the initial complications had been pericardial effusions without further sequelae, whereas in the control group, most of the complications had been stroke and bleeding, which are for sure much more severe than pericardial effusion. And these curves are merging because complications continue to occur in the control group. Are the complications unavoidable related to the procedure, or are they operator dependent? Well, fortunately, they are mainly operator dependent. And when you look at the learning curve, these are the safety event rates. And you can see, let's concentrate here. This is the PROTECT-EF trial in the early phase of recruitment. This is in the late phase of recruitment. And these are, it's the continued access registry, which means the same protocol after finishing the PROTECT-EF trial. Now look at the procedure-related safety adverse events within 7 days. 10% in the early phase of AF, 5.5% in the late phase, and 3.7% in the registry. Serious pericardial effusion, 6.3%, 3.7%, 2.2%, and procedure-related stroke went down from 1.1%, 0.7% to 0%. So there's a steep learning curve for this procedure. Now let's compare the PROTECT-AF trial overall, and let's compare this with the continued access registry. So 7.7% compared to 3.7% and so on. And let's imagine what would happen if we repeat the PROTECT-AF trial today with the operative experience we now have. What will basically happen that this curve will shift up because we will have less complications in the initial phase of the procedure, which means these curves will merge even earlier than they actually do in the current situation. So in PROTECT-AF, patients had to take anticoagulation for 45 days after device implantation. So what to do in patients who cannot take anticoagulations at all? And these are actually those patients we most often get referred for left atrial appendage closure. And now we have some results from the ASAP trial, which is a similar protocol as the PROTECT-AF trial, same inclusion-exclusion criteria, but anticoagulation contraindicated. And we have some results of 127 patients. And what you can see here is the peri-procedural complications, just one pericardial tamponade, 2 device embolizations, which could be, the devices could be retrieved by catheter techniques, and 1 pseudoaneurysm in the groin. So overall, the same rate of complications as in the PROTECT-AF trial, even less than that. And sorry, let's go back here. So which means the left atrial appendage closure is as safe in patients who cannot take anticoagulation as in those patients who are able to take anticoagulation for the first 45 days, as in the PROTECT-AF trial. There's another device which is available in Europe, at least. I don't know whether it's available in India. It's the unplugged cardiac plug, ACP, which looks like a little bit like the ASD devices. The concept is a little bit different than with the Watchman device because we have a plug which is inserted into the left atrial appendage, and then we have an umbrella which closes off the orifice of the appendage. And we also have a number of new approaches, new devices to close the left atrial appendage. The Santrohat is probably the most one, which is most advanced and which is available in Europe. It's a technique to close the left atrial appendage via pericardial access. So we do a transeptal puncture, introduce a magnetic wire into the left atrial appendage. Then there is a sheath in the pericardial space, and then we introduce a second wire into the through the pericardial sheath. These 2 wires are finding each other and they connect them, and then we introduce via the pericardial sheath a snare which goes over the appendage and closes the left atrial appendage orifice. And this shows you the image before left atrial appendage closure, and this shows you the image after ligation of the left atrial appendage. This is a very nice technique which has some advantages compared to the device closure of left atrial appendage. This is some advertising for our course about left atrial appendage closure in November here in Frankfurt. So my take-home message is atrial fibrillation is a frequent cause of stroke. Anticoagulation therapy is effective but difficult. Thrombi originate from the left atrial appendage. Catheter closure of the left atrial appendage is a causal treatment, is feasible, relatively safe, and equivalent to anticoagulation. Technology and operator experience are constantly improving. Thank you very much for your attention.
Thank you very much for the excellent presentation. And I'm sure they have lots of questions, but because of the paucity of time, can we take some questions? We have some time. Dr. Khanna says that. Any questions from the floor and or from the podium? As far as the friendliness concerns about the two devices, which will you find more user-friendly, Implantat device or the Watchman? Because there's a lot of
both. Yeah, I think both devices do a good job. They have similar learning curves. It may be that the Watchman device is a little bit more forgiving regarding sizing and position of the device, but there's not a big difference. So I think they are really comparable.
And how do you do sizing? Do you have any kind of sizing balloon, or how you do the left atrial sizing? Or from the echo
sizing is
enough?
Done, and we will see this. I will show you a recorded case of left atrial appendage where we will see the sizing. So it's based on TEE and on angiography.
Yeah, one question. A lot of patients in India, we have rheumatic heart disease. As of now, we are doing all these interventions for non-valvular atrial fibrillation. Do you feel any scope of these, doing for rheumatic heart disease where the atria are large and...
Well, if you are talking about rheumatic heart disease in general, it's difficult to say because thrombus may also form somewhere else in the left atrial appendage, as you better know than I do. But always the question comes up what to do in patients with mitral valve stenosis where you do valvuloplasty. And I think this could really be a good indication that you do mitral valvuloplasty and immediately thereafter you have already access to the left atrium and then close the left atrial appendage. I think this would be a good indication. Obviously, it needs some kind of a trial, but this is the way to go in your specific situation with rheumatic heart disease.
Thank you.
So if there are no other questions, I would suggest that we proceed with a recorded case of left atrial appendage, which was done during one of our courses. Is that okay for you?
Yeah, that's fine.
Okay.
A 76-year-old man with permanent atrial fibrillation. The patient also has arterial hypertension. The ECG showed an atrial fibrillation and an indeterminate axis. TTE showed a hypertrophy of the left ventricle and a dilated left atrium.
So what we see at the moment is a big view at about 105-degree left atrium in the upper part of the picture. And this patient has a little PFO, and we try to go through the PFO to close the left atrial appendage. And this is a short view of the left atrial appendage. So we measured it in several views, and the largest diameter at the orifice was about 21 millimeter, and it's about 34 millimeter long. So that's a suitable left atrial appendage for the procedure. And we didn't find any thrombus so far.
I have the sheath in place which comes with the Toronto transeptal catheter. I'm just removing the wire here, and then I will introduce the radiofrequency catheter. So now I'm just at the tip of the sheath, right? Of the dilator. Okay.
He's using 10 watts for 2 seconds.
Now, if you look at the pressure now, we clearly see that we have left atrial pressure. So we are across, but I don't see the tip of the...
So obviously, usually we don't use the radiofrequency catheter to do transeptal puncture. This was just for demonstration purposes.
I will advance the sheath.
Well, you want to put the RF catheter fully all 5 centimeters in the left atrium, so that the hub is touching the dilator.
No, I keep the dilator in place and advance the sheath only. So I'm retrieving the radiofrequency catheter, the sheath is across. At this time I can give heparin. Should never give this before you have crossed the septum. So what I like to do to engage the left atrial appendage is to use a small pigtail catheter. In the instructions for use from the Artritech device, it's recommended to use the sheath, but I think it's more atraumatic to use a pigtail. Okay. Okay, I think that is a better position now. I was in a small lobe. So now I have an Ampert's extra stiff wire in place and pulling back the pigtail. There's a specific designed sheath for the Watchman device. So this is outer diameter is 4.4 millimeters. So that is about 12 French inner diameter and 14 French outer diameter. So I'm retrieving the transeptal sheath, which comes with the Baylis catheter. So I'm advancing the sheath now. So at this point, I will advance the sheath only. Well,
as you know, the wall of the left atrial appendage is very thin, so you have to be very careful to manipulate into that area.
Look at that. Look at the anatomy of that left atrial appendage here. It's much more complex than we initially thought. There's an additional lobe. So this was 30 degree RAO, and now we have 30 degree RAO and 20 cranial. And we did a number of measurements, and the average measurement was 20 millimeters. And they have a spreadsheet where you can see that for 20 millimeter LAA, 24 millimeter device is the best choice. And I already have it introduced into the sheath. It comes preloaded, so I can't show it anyway. So the very last step is that I introduce the delivery system into the sheath, and you will see that there's a small clicking mechanism at the end. We'll do this on the fluoro here also. So now the delivery system and the sheath are connected. Then I will open the Fourier-Borst here, keep the metal piece in place, and pull back the whole thing, so this will expose the device. You will see this on TOE and angio. Okay. So I think it looks pretty good. If you look at on the angio, on the superior border of the appendage, it looks like that it would be nice to have the device a little bit more outside towards the left atrium. On the other side, if you look at the inferior border, it's just at the same level where the orifice starts. So I think that is, regarding angio, it looks pretty good. Nina, would you like to comment on the findings on echo?
It's the same in echo, so the inferior part sits very well, and it seems to be, you already did a chart test, or?
No, I didn't do that.
Mm-hmm. But it fits in quite well. So we just look for the compression. This should be about, so the device size you found in here is 21 millimeter, and that's a nice compression when the device is 24 millimeter before. We want to have a device compression in between 8 and 20%. Yeah, there's a little bit of residual shunt, as you can hear, to the rim's left upper pulmonary vein. But we usually see this in this stage, and it's a very small one.
So now we'll measure the diameter of the device as it is in the left atrial appendage. We have 21.8. Is that acceptable? So please look at the fluoro now, and you see that I did a TAC test. That means I injected contrast at the same time I pulled on the device. And you can see that the proximal marker of the device and the tip of the sheath are moving together. And they are approaching each other. And at the same time, I'm pulling a little bit on the device. You can see that the device is moving together with the left atrial appendage, which means we are in a good position here. We also measured the diameter of the device as it is implanted now, and compared to these to the recommended diameters, and that also looks fine. So I think at this time we can release it. And to release it, I turn this little knob here counterclockwise. So it's a micro screw there. You can do this under fluoro. Okay, so I think a final look on echo. Nina, is everything fine there?
Yeah, we already scanned the fuse, and it looks fine. We've got a really small residual shunt, but as you also already heard the comment, so this is very small actually in the 45 days follow-up, and I think it's acceptable. It's a good position.
Perfect. So I think Becky should move on to the next talk if there are no other questions.
I think we should stop here. So coming back to the question of sizing, this is a case I did actually some years ago. So what we now do differently, we measure the diameter in different views with angiography and with TEE, and then we always go for the largest diameter we have measured in the different planes. And then the device has to be oversized by 10 to 20%.
Right, that's the practical tip, because it has to be not oversized. The 10% is approximately higher than what you anticipate should be okay. Is there any mechanism to recapture the device or reposition the device if you think it is not satisfactory? Like the upper part of the device was looking little not in that much contact as the lower one. Is there any way to do it?
Actually, the gap we saw on this TE image is probably outside of the heart, outside of the left atrial appendage. So in retrospective, I think that was a perfect position. But if you don't like the position, you can partially reposition it. You can pull it back into the sheath, but you cannot pull it completely back, because in that case, the little hooks may get damaged. So if you have to retrieve it completely, then you have to use a new device, which usually you, by the way, you will get for free because they have a kind of a placement guarantee. But you can partially retrieve it into the catheter, reposition it, and then redeploy it.
Are there any cases where the device has been deployed and it has came off from the place and you have to retrieve it or recapture it by a snare or some other technique?
Yeah, it's a very rare event. So I think we had overall, over the last 5 years or so, one embolized Watchman device and also one ACP device. They usually can be captured quite easily, especially the Watchman is very soft, so you can grab it somewhere, anywhere, pull it with a snare into a big sheath and retrieve it without certain problems. Also, the ACP device can be retrieved. That you should pay attention with the ACP device to grab it at the hub where the screw is, and then you also can pull it back into the sheath and retrieve it quite easily.
In today's time, what would be the indication of using a center heart device?
The indication for the most important indication are those patients who cannot take any kind of drugs, who cannot take warfarin, cannot take aspirin, cannot take Plavix, because with this technology you are suturing the appendage from outside, which means there's no foreign body left. So this would be the ideal indication. But I think it's overall a technique which is also good for all other patients. The only hassle is that you have to learn pericardial access. And when I started this, I thought, oh my God, how difficult is that? But in fact, it's not so difficult. So it's a very nice technique. I think it may be more often used than other devices in the future.
Is there a risk of pericardial effusion or a tamponade with doing this technique?
Well, actually, with all these devices and techniques, there is some risk of pericardial effusion. You remember my slides about the complications with left atrial appendage closure. But with the Sondra heart technique, treatment is already there because you have pericardial access, which means even if bleeding occurs, and if it occurs, by the way, it occurs most often from the puncture side, then you have the catheter already in place. And what we do after the central heart procedure, we leave the pigtail there and for 24 hours. So if any bleeding or fusion occurs, it's already drained. So that is the beauty of this technique, that all the complications which occurs with the devices cannot occur. So pericardial fusion is already treated. A device embolization cannot occur because there's no device. Thrombus formation cannot occur because there's no foreign device. So I think it has a lot of advantages, and the only disadvantage is getting pericardial access.
I presume the access to pericardium in this device is percutaneous. So in a pericardium which doesn't have so much of fluid, gaining access to pericardium percutaneously, did it have any problems? It must have been done under echo guidance, or especially
actually it's done actually more on the, it's not done under echo guidance, it's done under fluoro guidance. We are using a Fui needle which has an oblique tip, and I mean later on we have two options today. I don't know how late we are running. We can show a TAVI case at the end, or we can show a central heart live case recorded. So that's up to you. But it's done in the fluoro guidance. It's not so difficult. Actually, EP doctors do this very often for their procedures.
Is there any risk of stroke post-deployment? Do you have any data on the post-deployment cases? It's 0%, or there are some cases who can have a stroke later on also?
Yeah, you can reduce the stroke. I showed you the slides. So ischemic stroke has been reduced by 22% and hemorrhagic stroke by 75%. So there is some risk because these are elderly patients and they have other reasons for stroke. Also, there is a certain risk of thrombus formation on the device, which is around 2%, which also may be the source of an embolic stroke. So it's not going to zero, but it's reduced to the same degree as with anticoagulation.
Thank you very much, Dr. Scheller, for this nice presentation, and you and your team, we all salute you for this. And next with this, we can move to the next part of your presentation, which is for the renal artery sympathetic nerve denervation for the treating resistant hypertension.